Hello, everyone, and welcome to today's webinar, Amnesty for Alcohol, Emergencies, Benefits, Barriers, and Opportunities. My name is Orlando Cooper, one of the graduate assistants at IHEC, and I'll be your moderator. I am assisting Madison, the Assistant Director for the Illinois Higher Education Center for Alcohol, Other Drug, and Violence Prevention, and we are very excited to be hosting today's event. Before I hand over the microphone, I have a few housekeeping items to cover about today's webinar and the GoToWebinar platform. For those of you new to using GoToWebinar, you will see the control panel on the right of your screen. This is where you will find the question box that you can type and submit at the end of the presentation. All attendees will be muted for today's program, but that doesn't mean you can't participate. And I will hand over the presentation to Ashley.
Awesome. Thank you, Orlando. Hi, folks. My name is Ashley Holla, and I'm the Director of Wellness and Prevention Services at Babson College in Wellesley, Massachusetts. I am a social worker by training and education. I currently have oversight for Babson's public health initiatives, as well as I'm a clinician. So I oversee the clinical care for students who have experienced sexual violence or substance use. So the topic that we're covering today is one that is really special to me because it sort of is a beautiful intersection of our public health initiatives and our clinical work that we do with students. So today I have the pleasure of speaking with you all about Amnesty for Alcohol Emergencies, Benefits, Barriers, and Opportunities. So today, I will explain the range and variation of amnesty policies, including related historical perspectives. We will identify barriers to campus adoption of amnesty policies. We will also outline methods to advocate for writing or maybe improving your amnesty process. So there are many different names for what we're going to be talking about today. Medical amnesty is popular, just amnesty, Good Samaritan, these are all variations. Essentially, their purpose is to protect people from punitive measures for assisting in overuse emergencies regarding alcohol and drugs. The research on how amnesty came about and its current prevalence is limited, which we'll discuss later on. But a few early adopting institutions, legal cases, and media coverage may have influenced its rise in popularity. First, the earliest policies that are noted were at Dartmouth and William and Mary, formulated in 1987 and 1990, respectively. Second, in 1989, the Drug-Free Schools and Communities Act started requiring institutions of higher education to formally notify students of alcohol policies and sanctions. It's thought that the popularity of amnesty rose after this because schools were made aware of a potential conflict between students needing to ask for help for themselves or a friend, or getting in trouble. Lastly, liability, legalities, and media coverage contributed to the rise in amnesty policies. In the late 90s, courts were typically not finding institutions liable for deaths or injuries related to alcohol use. However, in 2005, institutions were found by the courts to have a legal duty to use reasonable care to prevent injuries to students arising out of events where alcohol is served and available. This was after two high-profile suits versus the University of Nebraska and the Beta Phi fraternity. Shortly thereafter, the very well-known Scott Kruger case at MIT was settled out of court for $6 million, a public apology, and the undertaking to perform activities and policy changes. Perhaps out of both the concern for students and the fear of lawsuits, schools started implementing amnesty policies to reduce barriers for calling for help. More recently, it's common for families to sue students involved in providing alcohol or fraternities with heavy drinking traditions that may lead to death. For the prevalence of medical amnesty policies, this information is difficult to find, as there really hasn't been a widespread survey of institutions. However, the Students for Sensible Drug Policy, that organization, they did do a count in 2016. There's little information on their research methodology, and it is hard to believe that out of all the US institutions that exist, that only 230 have some form of medical amnesty. But this is the best information we have as of today. Not only have institutions of higher education adopted amnesty policies, but many states have as well. This is getting more well known with the opioid crisis. So far, 39 states have enacted medical amnesty. As a couple of examples, Vermont, Maine, New York, Massachusetts, and Rhode Island all have medical amnesty policies. So I want to introduce just a couple of grounding questions that will serve as sort of lead-ins and agenda items for our next section of the presentation. So I want you to just sit and think for a second. Are the faculty at your institution aware of the amnesty policy or process? Are staff aware? And maybe most importantly, are your students aware of your amnesty policy and or process? On this slide, you'll see the amnesty policy that's been adopted by Babson. 5 years ago, Babson's policy was often misunderstood, the process was underutilized, and various stakeholders had conflicting perceptions of amnesty and its use. The first significant step forward was the hiring and onboarding of Babson's first Associate Dean of Students for Wellness, and the subsequent organization of a formal health and wellness department. Next, there was a need to establish trend data. At the time, data related to amnesty was not collected. One of the first actions taken by Health and Wellness was the production of a monthly alcohol and drug emergencies report. This report includes data on any and all medical emergencies related to substance use, including medical amnesty. After beginning to collect data, Health and Wellness gathered appropriate stakeholders to provide feedback and reflections on the report. The report itself serves as a common agenda for the bringing together of various offices such as Health and Wellness, Community Standards, and Public Safety. So another set of guiding questions here. Is the amnesty policy or process at your institution effective? And if it is, how do you know? Do we measure it by awareness, by knowledge, by the number of calls, by an increase, decrease, or plateau of alcohol emergencies? What are we using to sort of indicate, is this policy effective? Now, critics of the amnesty policies are concerned that it can be enabling, but the literature strongly disapproves of this view. The literature does not cite increases in risky substance use, such as heavy episodic drinking, when amnesty policies are in place. Haas and Wickham, in a report published in 2018, found that there was no increase in risky drinking for entering freshmen after medical amnesty was implemented. Research on amnesty is challenging because each school has such a different policy. There's different factors that influence students' behavior or use of that policy, and then there's different ways of measurement. If we measure by utilization, we need years of data to make a solidified statement on the effectiveness due to the spike at implementation, the plateau, and then perhaps the drop. How is awareness measured? Is it that students have read the policy? Well, many are required to read it. Is it that they know when to make a call? We can measure knowledge based on this, but it's difficult to measure behavior. And lastly, how does the drinking culture at the institution influence this? What if it changes over time? Again, a couple of grounding questions here for us to just sit with for a moment. Do the students at my institution understand the amnesty policy and process? And maybe, again, more critically, do the students at my institution trust the amnesty policy or process? Early in my career at Babson, we had the opportunity to onboard a new athletics director. Early in his tenure, he approached the health promotion and prevention team, which is the team that I have oversight for, and he approached us with an ask. Essentially, the athletics director asked for a selective prevention effort, specific prevention programming for varsity athletes, focused primarily on substance use and sexual violence. After much thought, after much back and forth, we came up with an idea. The idea was big. The idea centered student athletes and coaches as educators. The idea was high risk and high reward. This idea was called Project Team. Project Team is a 4-workshop-based intervention that is explicitly designed to mirror the social ecological model. In order to effectively implement this big idea, we needed funding, we needed structure, and we needed support. Shortly after developing our intervention, we found that the NCAA Choices Grant. The Choices Grant is a 3-year award where you get $15,000 in year 1, $10,000 in year 2, and $5,000 in year 3. We applied for the grant and we received it. Upon receiving that grant, we had a pretty good plan for workshops 1, and we really began to conceptualize workshop 2. Now, at the time, workshop 3 and workshop 4 felt a bit more nebulous because we really wanted to learn from the first 2 workshops before crafting curriculum for workshops 3 and 4. We also felt that we really needed to honor advocacy in the design of workshop 3. In wanting to teach students how to advocate, we needed to identify an opportunity for change and influence with the athletes. This was going to take time and trust and some structure for receiving this information. One requirement of the NCAA Choices Grant is to attend the Apple Conference at least once in your 3-year grant cycle. We attended our first conference in January 2018. We brought 2 health and wellness staff and 3 student athletes as a part of our delegation. Now, there's a couple of things that you need to accomplish at this conference. And the most significant deliverable is an action plan. This action plan, really needs to be student-driven. Staff and faculty who attend the conference can be a part of the process, but really you're positioned as a listener. For us, this was an interesting process because we had, again, those 2 health and wellness staff, both confidential resources, including myself, present at this conference, and we had no athletic staff. This has since changed as we continue to go back to this conference, but at the time, we just had 2 confidential health and wellness resources and 3 students. And I gotta be honest, at first, it was really difficult to populate this action plan. It was this really sort of long, form that we had to fill out, and we kind of stared at it together as a delegation, really wondering what is the plan? What is the one thing we want to change? Where is the opportunity for influence? Where can we advocate? So we were going to this conference and we were, again, tasked with doing this action plan, and we weren't really sure where we wanted to go with it. And one evening at the conference, there was a screening of the movie Haze. To be honest, our delegation didn't really know what to expect when sort of watching this. So the lights went out and we all began to watch the film, which tells the story of an alcohol-related death. The room was dark, and so we were all kind of watching this, and I wasn't really in touch with what my students were experiencing up until they turned the lights on. So they turned the lights on, and then I could see that my students were really in shock. So we walked back to our hotel after this screening had ended, and I looked back at my students, and some of them had started to cry. And so we stopped actually right by the pool, and we sat on these pool chairs as sort of the group of 5 of us and really started to break this down. And essentially what happened is these athletes started telling us stories about times when they watched their teammates nearly overdose because they were really scared to call and ask for help. We heard about teams that wanted to protect their players. We heard about people who didn't want their parties to be adjudicated. We heard about fear of missing playing time. And so we essentially came up with what we call the central hypothesis to workshop 3, which was this: that student athletes are less likely to benefit from the amnesty process and therefore are less likely to call for help in the event of an alcohol or drug emergency. So we found workshop 3. We found our opportunity for change. We found our opportunity for advocacy and influence, and we wanted to make sure that the student athletes had a role in coming up with some sort of goal or solution. So the implementation plan for workshop 3 is exactly what you see here on this slide. The first thing that we wanted to do is we really wanted to honor these students who went to this conference and shared this information. So we really put them in the driver's seat as far as making sure that they felt communicated with, that their stories were represented accurately, and that they had a voice in what was going to happen next. The next piece, step 2, was really communicating with key stakeholders to gauge community readiness to address this issue. Key stakeholders for us at the time included community standards, health and wellness, and the athletics department. Then we wanted to gather some additional data. So we knew that project team as a workshop was going to give us a lot of information, but where else could we get data? And for us, it really lived in two different places. The first was our community standards or student conduct data, and the next was data from the NCHA, or the National College Health Assessment. Next, we had to design the workshop curriculum itself. So I wrote the workshop 3 curriculum, and it included a couple of different pieces. One was a piece on why rules matter, and we talked about the rules in sport and why certain rules exist, and really sort of emphasizing that rules are created for safe, fun play, and how might that translate to the rules that we have at colleges and universities. The reason we did that is we wanted to position policy and rules as an asset to our students, not a limitation to our students. Next, we defined advocacy, and we had an activity, which I'm going to go over with you in a moment, called advocacy in practice. And lastly, we did have some pieces around being an active bystander in this curriculum as well. The entire project team program had a really robust research design. And so you'll see a little bit of the data that we gathered from workshop 3 research design, but it was inclusive in a larger set of surveys. We also ran train the trainer workshops for coaches and students, and I'll talk about that in just a second. And then the last step would be making sure that all 22 of our varsity teams completed this particular workshop. So advocacy in practice was the main activity in workshop 3, and it basically looked like this. We listed the definition of advocacy, so what is advocacy, in the facilitator's guide. We wanted to make sure that we created some nomenclature, some shared language around what are we talking about when we're trying to position student athletes as self-advocates, right? So we listed a common definition. We also had an opening statement related to information sharing and transparency. We were asking the student athletes to give us information about why they do or do not call for help. And we wanted to make sure that their information was protected. So we really clearly said, hey, here's what we're looking for from you. Here's exactly where that information is going to go, and here's how it's going to be used. We provided some of that guidance to them. We introduced this hypothesis, this concept that, are student athletes less likely to call for help and then therefore less likely to benefit from the amnesty process? Do you agree with that? Do you not agree with that? Tell us why. Help us understand this. And then we ran small group circles, and the small group circles accomplished a couple of things. Again, do you agree with this hypothesis or not? What barriers, if any, exist to you calling for help? What solutions can we come up with to make those barriers less pervasive? How do we think about our stakeholders? So we would not only have them, first identify these barriers and then identify solutions, but then as part of the circles, we had a couple of student athletes representing key stakeholders. So they were given stakeholder cards, which included some key questions that those folks might ask. As an example, community standards had a question on their card that was basically saying, is this fair and equitable for athletes and other students? Is this solution something that is fair and equitable? Maybe a card with a coach on it might have said, is there accountability to the team? And in what way might that exist? Health and wellness might have been, is there any harm reduction present in whatever your solution is to address that barrier? And so different athletes would play stakeholders in this circle. And then they would submit qualitative data based on group discussion. So we had facilitators not only leading these circles, but also taking really, really comprehensive notes to help us understand the depth of these particular conversations. So again, another moment for us to pause and reflect here. When you think about the amnesty process or policy at your institution, are there barriers to accessing it? Are there reasons that students, regardless of whether they're an athlete or not, are there barriers to students accessing this policy? And if so, what might be the most pervasive barrier? And I guess to go even further beyond that, how might we address it? So we train the athletes to facilitate these workshops with their teams. This activity was rather complex, and so we demonstrated this activity by facilitating it first ourselves with the facilitators in a train the trainer model with them as participants. This was really, really interesting. First, the athletes were way more open than we expected, especially because this was essentially a role play. They didn't have to give us real information or any information with depth, but they did. And not only did they do that, but they did it with their coaches in the back of the room, which really surprised us. We also had our director of community standards at most of these sessions present in the room, which we hoped would add a level of transparency and trust, and I think it did. We learned quite a bit as well. We learned about the barriers, many of which we hadn't actually ever thought of. One example is the lack of privacy when sirens and lights from a police car are sort of running through campus to go assess a person. We also learned that there's a lot of gossip around Amnesty. People get talked about the next morning, and how might that be a barrier that we can address? We also heard about some inconsistencies in response, whether from EMS, public safety, et cetera. And we wanted to figure out how we could provide some anticipatory guidance to sort of set the record straight, if you will. We also heard some things that were inaccurate. As an example, people not calling for Amnesty because they were worried about getting their stomach pumped, as an example. When we analyzed their work, we found that there were, after all the workshops were done, we found that there were 5 top barriers. The first was their coach finding out. There were a lot of concerns from our student athletes, particularly about the relationship with their coach. They were nervous and contemplative about, if my coach finds out, it's going to impact the relationship that we have, and it's going to impact my role on the team. And that was by far the most frequently reported barrier. The next was peer reputation, and this included both within your team, meaning your teammates would think of you differently, or somebody outside of the team would think about you or your team differently because medical amnesty was enacted. Financial cost was a significant barrier. Now, there are no fines or punitive related financial costs related to medical amnesty at Babson, but there is a pretty significant bill for riding in an ambulance. And that was a huge barrier for a good portion of our students. The next would be athletic consequences, which significantly is different from the coach finding out. So this might be loss of playing time, running extra laps, things like that. And the last barrier was simply a lack of knowledge about the process. And this included both a lack of knowledge about what is and is not an alcohol emergency, as well as just not knowing what's going to happen next. Not really having any anticipatory guidance around, well, what is the amnesty process and what should I be able to expect? So these were our top 5 barriers. And now they also, if you recall, they were charged with coming up with some solutions. And so our top 5 solutions across our 22 varsity teams were here. The first being some sort of interim step. And what I mean by that is something in between a medical assessment on site by, let's say, a public safety officer and going to the hospital. Now, many of our students call this like something like a drunk tank, or a place where people could be monitored or where people could rest in a way that is safe. So some sort of interim step. The next was further education. Again, this goes back to this idea that they didn't really know what an alcohol emergency was, and so they wanted to learn more. The next, letting students tell coaches. So this would be letting students tell coaches instead of another administrator or staff member telling the coach. No data sharing. This was actually sort of an antithesis to the last one, meaning that nobody tells coach, meaning that the data around somebody with any sort of conduct issue stays within conduct and doesn't get shared with the coach. And the last was some online education or video to, again, help educate our students around this process and alcohol emergencies writ large. Now, one thing we found really interesting about this is the top 5 solutions don't necessarily or explicitly line up with the top 5 barriers. So it really taught us a lot about how our student athletes are thinking about amnesty and where they think they have a level of influence or authority in this conversation. So the next steps in this process were as follows. We wanted to review the data with the Project Team Advisory Committee. This is a cross-functional team that includes students, staff, athletics administrators, other campus administrators, and then we also wanted to share this with SAC, the Student Athlete Advisory Committee, which was actually redesigned this past year to mirror Project Team, and they were really motivated to get things done. We also wanted to make sure that we got this feedback right. And so that's one of the reasons we went back to the Student Athlete Advisory Committee, is to share these barriers and these solutions and to say, you know, hey, did we capture this correctly? Does this feel right to you? And just for context, our Student Athlete Advisory Committee has 2 representatives from each team, so it's just under 50 students, which is pretty significant. Then we took this to stakeholders. The stakeholders that were defined in our activity were ourselves in health and wellness, community standards, and athletics. We also added public safety to this list, and perhaps EMS services and other community members, because the feedback that we got from our athletes really took us there, and we wanted to meet our athletes where they were in regards to these barriers and these solutions. So not only did we get a lot of qualitative feedback from this workshop, but we also got a lot of quantitative feedback as well. One thing that you'll see here is a set of questions around, experiential questions around calling for help. So the first one was, have you ever been in a position where you thought about calling for help for someone else? But 23% of our athletes said yes. Now, of that 23%, we asked them, in that situation, did you call for help? A little under half said they had, about 43%. And of that 43%, would you call again? And 82% said yes. And we were really excited to see that many of our students who have called for help would do so again. Another question that we asked our students was to select the most important reason why you individually would not call for help for someone else in the event of an alcohol or drug emergency. As you can see, our top reason, coach finding out, matches this particular answer as an individual. So again, when they were in those circles and in those groups, coach finding out was that top barrier. And this was just sort of solidified here when the individuals were answering their own surveys right after the circle and the sessions. After coach finding out, though, it's really a mix from there. To take care of them myself, this was an interesting answer because they expressed so much concern over not knowing like where the line is, not knowing what an alcohol or drug emergency is versus when they need to call for help. Reaction from the team, stigmatization of calling, they were both at 5%, and put together that makes the next highest barrier. And then meeting with community standards and the perception that athletes receive higher sanctions. Many students felt that this way since they had to meet with community standards, talk with their coach, maybe their team, maybe their captain, and there might be additional consequences such as loss of playing time, as an example. And this was really bothersome to our student athletes because the way that we market medical amnesty is no punitive action. And so the athletes really felt like, well, if we get punitive action that's just not through community standards, is it really medical amnesty? The next question that I want to go over is, we did ask the athletes, how likely is it that you or a teammate will use the amnesty process in the event of an alcohol emergency? So what you see here in gray is folks who rated their fellow teammates, and then what you see in blue is how they rated themselves. We were excited to show the athletes this because they rate themselves as much more likely to call for help than they perceive their teammates as being likely to call for help. And so this was a really affirming slide for us to show that individual efficacy was high. And before I close today and take some questions from all of you, I want to introduce one last piece of our approach to amnesty. We were very lucky in that one professor at Babson connected with us to infuse amnesty into her marketing management class for the semester. Staff attended one of the first class sessions, and we were introduced as the clients to these marketing students. We presented sort of our problem statement, again, that hypothesis, as well as transport data and other contextual information. And the students in the class had ample opportunity to ask questions. We also talked a bit about health promotion, harm reduction, and strategies that we understand really don't work, such as shame and fear-based messaging, especially because they're likely focused on consumer marketing in this class, and we know that the health marketing industry could use a bit more of that consumer touch. We're excited to see what universal information we really get from this class and how to market the medical amnesty policy to the entire Babson community. And then we need to figure out how to bring all of this back to our student athletes to, again, ensure a seamless approach to where we're going to take medical amnesty from here. Well, I really appreciate having the opportunity to tell Babson's story. We have a good amount of time here for questions and engagement from all of you. I'm going to put my contact information back up here if anybody does have interest in learning more about the work that we have done and the work that we're continuing to do around medical amnesty. And otherwise, Orlando, I'm going to hand it back to you to see if we have any questions from participants today.
Thank you, Ashley, for that wonderful presentation. And I'll give a few seconds for people to ask questions if they have any. Uh, there seems to be no questions coming in.
Okay, no problem.
If there are no questions, then I'll close the presentation with a closing segment by making a statement about keeping an eye out for an email after the presentation. The email will include an evaluation link, and that evaluation link will help us with future presentations. And it would also include asking for your CHES numbers. And please clarify if you do need your CHES numbers. The certificates will be issued within 7 to 10 business days from the webinar, and we will have the webinar available to view on the IHEC website. Thank you all for coming, and thank you, Ashley.
Absolutely, thank you.
And we don't have questions, but a lot of attendees are saying thank you. The
Beautiful.
presentation was interesting. Thank you, everyone. Bye.